obviously of great interest to all of us. And then whatever questions you have, I would love to try to answer if I can. So this is rationale and indications. These are my disclosures. I will show a couple studies, one from the ECMO and from ELSO as well. So just to make sure, I imagine the great majority of you practice ECMO on a daily basis, but to make sure that we're on the same page, this is from a review article we had in JAMA, just showing the basic setup of veno-venous ECMO, the typical setup for ECMO for respiratory failure. And just going through it, this is meant to show a cannula going up the femoral vein into the right atrium. And this is a drainage cannula draining venous blood via this pump. So there's negative pressure pulling the blood out as the pump then pushes that blood with positive pressure into what's called an oxygenator. And truthfully, we should call it a gas exchanger, not an oxygenator, because it both provides oxygen and removes carbon dioxide. That oxygen comes just from a blender, just like it does with a ventilator. It's either pure oxygen or a mixture of air and oxygen, and that's added into the oxygenator. This is what goes on inside the oxygenator. And here it says oxygenation and decarboxylation. That's actually a misnomer. We shouldn't have called it that. It's just removal of carbon dioxide. But you can see there are these mats of hollow fibers. This is inside the oxygenator. They're like straws, and the gas goes through the straws and blood washes over them. And in doing that, they exchange gas just like you would in the alveolus of a lung by diffusion of gases, the oxygen out of the membrane into or out of the fibers into the blood, and the carbon dioxide from the blood into those fibers. And then the carbon dioxide is released in the exhaust gas from the oxygenator. Here you have what is depicted as bright red blood because it's oxygenated and the carbon dioxide removed, then returns, in this case, and this is a very typical setup, to the right IJ as a reinfusion through a separate cannula, which you can see here in the inset. The blood returns to the right atrium with oxygen. You can see some blood may be pulled back into the cannula. That's recirculation, which is something we try to avoid. So that's the basic setup here. In larger, I guess this would be easier. But this is a separate paper now from Steve Conrad. This is on behalf of ELSO. Just looking at the nomenclature, it gets very confusing sometimes because we use some of the terms interchangeably. The choice here was to use extracorporeal life support as the overarching term for ECMO, extracorporeal membrane oxygenation, and ECOR, or extracorporeal carbon dioxide removal. Within ECMO is VA ECMO for cardiac failure, VV ECMO for respiratory failure, and then VVA or VAV for a combination of cardiorespiratory failure where you're using 3 or more cannulas. I won't get too much into ECOR today, but that's using the same kind of veno-venous setup, but simply at lower blood flows with the intention of removing carbon dioxide. It can also be done arteriovenous, but that's not very common in this day and age. And so I'll focus on VV ECMO and a little bit on VV ECOR. I think that one of the most important things for us to understand is, because it helps us to manage the patients during ECMO, is why would patients benefit from going on ECMO for respiratory failure? And so this is specifically for ARDS. One reason here off to the left is minimizing hypoxemia. So particularly for a patient who is profoundly hypoxemic, well, providing intravenous oxygen could be truly life-saving. That's a very small minority of patients, but it is definitely possible. And obviously, as we increase the PaO2, we decrease tissue hypoxia, we decrease multi-organ failure and mortality, and we may also improve long-term neurocognitive and psychiatric sequelae. We may also be minimizing hypercapnia in those patients who can't ventilate well. That can improve right ventricular afterload, increase cardiac output, and so on. And we might reduce diaphragm myotrauma, the trauma to the diaphragm that occurs with mechanical ventilation or this kind of rest, with sedation and so on. You can improve diaphragm function, ideally, accelerate weaning, and decrease ventilator complications. But the main mechanism of benefit is this one. So if we can minimize the stress and strain placed on the lung, then that's really where the benefit of putting somebody on ECMO is. So we talk about lung protective ventilation, decreasing volumes and airway pressures, decreasing respiratory rate, driving pressure, such that we can protect the lungs from the damage of the ventilator, from ventilator-induced lung injury. And ultimately what that does is decrease the various forms of trauma we call volume trauma, atelect trauma, barotrauma, and biotrauma, the release of mediators that actually cause distal organ dysfunction and multi-organ dysfunction, which is the main mechanism of death from ARDS. And that's both because of the underlying diseases like sepsis that might have resulted in the ARDS, but also because of ventilator-induced lung injury. So the main mechanism of death, of benefit, is to decrease even more than we normally would the volumes, pressures, and respiratory rates such that we can minimize ventilator-induced lung injury. Very important to acknowledge the complications associated with ECMO. You're all very familiar with the fact that ECMO comes along with many complications. Here we divide it into medical or mechanical complications as opposed to device complications. Of the device, circuit-related and cannula-related, and here by organ system. In the white are those with percentages that are listed from the ELSO registry, and in the gray are just additional complications that may occur. And obviously there are quite a few, and this is it's always a dangerous undertaking, only to be done in those patients we think can benefit the most. Very important to understand that ECMO continues to increase in volume. Obviously, in 2009, we saw a huge increase after the publication of the Caesar trial, as well as the H1N1 pandemic that year. And that was for all cases of ECMO, but really it tracks with all adult cases. And you can see there's an even split between the increase in adult respiratory and cardiac, although if you add in adult ECPR, you see there's a little bit more cardiac growth during that time. Along with this, also starting around the same time, you can see a growth in the publication volume related to ECMO. So the number of publications that were coming out each year associated with ECMO. But of course, the number of publications doesn't tell us that they're high quality literature. And so what is the quality of that literature? Here's a way of dividing it up and looking at the different potential indications: very severe ARDS, moderate ARDS, lung transplant, primary graft dysfunction, COPD, asthma, pulmonary embolism, and pulmonary hypertension as the primary examples. Whether it's a clinical or research indication, I would consider acute exacerbation of COPD and moderate ARDS to be research indications, and whether it's ECMO or ECOR. And then here's the highest level of evidence. So randomized controlled trials only exist for very severe ARDS, and moderate ARDS is the highest level of evidence. And moderate ARDS being a research indication, you'll see very soon the REST trial from Danny McCauley and James McNamee in Belfast is coming out and will show no difference in patients with moderate ARDS for using ECOR. So I would still consider that a research indication. However, for now, I'll focus on the severe ARDS because that's really the one clinical indication where we have randomized controlled data. The two major studies, this is the first, that inform that are really the key studies to know. And so one of those is the Caesar trial that I'm sure you're all familiar with, which was by Giles Peake and colleagues, published in The Lancet in 2009, as I had mentioned earlier. And this was a randomized trial of 180 adults with severe but potentially reversible respiratory failure. And it's important to note that this was not a trial of ECMO versus no ECMO. This was a trial which randomized patients either to stay at a conventional management center to be managed under a ventilator, or a few referral centers that could send them to one of those management centers, or you were randomized to go to one hospital, Giles Peake's Hospital, Glenfield in Leicester in the United Kingdom. And if you went to that hospital, you weren't necessarily put on ECMO, because let's say you were already getting better by the time you were randomized and got to that hospital, it wouldn't be appropriate to put you on ECMO, so they didn't. Or if you were already moribund and it clearly wouldn't benefit, they also appropriately didn't put you on ECMO. So only 76% of patients in that arm actually received ECMO, and none in the control arm. And so it's a trial really of consideration for ECMO as part of a larger management protocol that they enacted once you got to Glenfield. And with that in mind, this is the result, which is that the primary endpoint of either death or severe disability at 6 months was much improved in the ECMO arm in the red. And that's a 16% absolute reduction in the primary endpoint, which is a huge potential benefit. However, the key is there are many sort of shortcuts to the trial. And the one that I would point out that I think is most important to know about is that the patients in the control arm didn't necessarily receive conventional lung protective ventilation that we were just discussing. And so and 70% of them received it at any point during their course, so that if you don't provide the standard of care to the control arm of a randomized controlled trial, or you don't guarantee it, as in this case, then you bias the results in favor of the intervention arm. All of that to say that this is a very impressive result, but it's hard to interpret under the circumstances of some of the caveats of this trial. What it did show that even though they were using roller pumps in those days still, that ECMO is relatively safe, and that there's probably a benefit of providing ECMO at an expert center like Glenfield Hospital as part of a larger management algorithm. But it didn't really answer the question of whether or not ECMO saves lives in severe ARDS. And for that, we have the EOLIA trial, which was published in the New England Journal in 2018. Again, probably you're all familiar with this. This was one of our ECMONet studies along with the REVA Research Network. And Alain Combes, who led this study, really deserves a tremendous amount of credit. It's a multi-center international randomized trial of 249 adults with ARDS. Randomization here could take place either at ECMO centers or non-ECMO centers, but you were put on ECMO even if you were at a non-ECMO center and then transferred with ECMO. All of the centers in the study had extensive experience managing ARDS with a low-volume, low-pressure ventilation strategy, including prone positioning. These are the three criteria that were used for an indication for ECMO in the trial, or for an indication for being randomized in the trial. And it's important to understand these criteria because if we believe that EOLIA was a positive trial, then these are the criteria we would use in order to justify putting somebody on ECMO. So the first is a P to F ratio, less than 50 for at least 3 hours. So profoundly hypoxemic, and that was a very small number of patients. The most common indication was a P to F ratio less than 80 for at least 6 hours. And then the one criteria which probably showed, at least in post-hoc analysis, the greatest benefit to the patients was the patients with stiff lungs. So you're trying to ventilate them, but you can't maintain a pH above 725 with a PCO2 of below 60 for at least 6 hours, despite increasing the respiratory rate to 35 while maintaining the plateau pressure of 32 or less. So they're so stiff that you can't maintain the plateau pressure low without developing a severe respiratory acidosis. And as I say, those patients probably benefited the most, so it's a really important criteria. 249 were randomized, 124 to receive ECMO, which 121 of them did receive it, and 125 to conventional management. Very important to note that 35 of those patients ended up crossing over into the ECMO arm. In other words, they were put on ECMO because they met very strict criteria for crossover if they were essentially dying without ECMO. And that's 28% that crossed over, which biases the results to the null and will make a trial, if there were to be a benefit, much less likely to show it. And in fact, the trial was stopped for futility after the fourth planned analysis. This is the primary outcome of the trial, 60-day mortality. And you can see that the ECMO arm had a 35% mortality compared to 46% in the control. And that's an 11% absolute reduction in the primary endpoint. So that's a huge improvement, better than we see in almost any critical care trial. However, the p-value was 0.087. It was not statistically significant by a traditional approach, frequentist statistics, which is what we chose to use in the trial. A few other things to note: the amount of prone positioning. So in the control group, just to show that they received standard of care, 90% of them received prone positioning, which at the time of the trial was exceptionally good. And even in the ECMO arm, 66% overall received it, including a number who received it during ECMO. This is bleeding, you can see, was more common in the setting of ECMO. There were a couple more cases of massive transfusion, but not very significant. And this is interesting food for thought. We always think about ECMO as being associated with stroke, particularly hemorrhagic stroke. You can see that there were actually fewer ischemic strokes in the ECMO group, as well as hemorrhagic strokes, one more massive stroke. So it's not at all clear that ECMO itself is associated with stroke and not just being critically ill, at least under the conditions of this trial. So this is the conclusion in the New England Journal, and this is what the editor-in-chief at the time, Jeff Drazen, had required us to put as the conclusion, which was appropriate. Among patients with very severe ARDS, 60-day mortality was not significantly lower with ECMO than with a strategy of conventional ventilation that included ECMO as rescue therapy. That's interesting. So in other words, it's a negative trial. But one of the two editorials was written by David Harrington and Jeff Drazen himself. Those are editors of the New England Journal. And they said that it's important to remember that we can still learn something positive from a negative trial. And they went on to say that ECMO probably has some benefit in this context. So it's very interesting that the editor-in-chief of the New England Journal says, well, you have to say it's a negative trial, but then goes on to write an editorial saying, yeah, but it actually looks like it's probably positive. And what does that speak to? It speaks to this concept of Bayesian thinking. And it's just a different way of approaching statistics. We're very used to a frequentist analysis involving p-values and null hypothesis testing. But Bayesian thinking involves acknowledging the fact that we all come in with biases. And those biases can be based on prior literature or our experience. But when we interpret data like the Caesar trial, those who believed in Ecmo looked at Caesar and said, oh, it's definitely positive. And those who didn't believe in Ecmo said, oh, it's definitely negative, both based on Caesar. And so we're clearly bringing in our own biases, but we're not measuring them. With Bayesian analysis, we try to measure our biases and then come up with the answer of whether or not there is actually improvement based on the intervention. And so this is a study based on Eolia. This is a post hoc Bayesian analysis of Eolia led by Ewan Goliger, which we published only a few months later in JAMA. And the key is, and the one thing we didn't know ahead of time is we hadn't determined what the prior assumptions were of the community. So we gave a range of prior assumptions from being strongly enthusiastic about ECMO, moderately enthusiastic, skeptical, or strongly skeptical. And so if you were strongly enthusiastic beforehand, then the relative risk, the prior probability, this is a probability curve, one represents no difference. You thought it had a great deal of benefit. Once you put in the Eolia information plus your priors, then you come out with a posterior probability, and the posterior probability still falls almost entirely to the left of one, meaning that there's benefit. Whereas if you were strongly skeptical, your prior was the yellow-orange line here, which was centered on one, meaning we said that people who are skeptical would say that you're just as likely to kill patients with ECMO as you are to help them. And your posterior look was dragged way to the left of one, showing that even if you were strongly skeptical ahead of time, with the Eolia data, there's most likely a benefit. And so across a range of prior assumptions about the probability of benefit, the posterior probability, what we come to after the fact is of any mortality benefit, relative risk less than one, is 88 to 99%. So what does that mean? Like, we're standing at the bedside, we're trying to talk to the family and say, well, there's this intervention, ECMO, that you qualify for. And I can tell you that the likelihood of benefit is somewhere between 88 and 99% that it will benefit mortality. Well, that sounds, very good, rather than there's an 11% difference in mortality, but it's not statistically significant. And it's a negative study, makes it sound like something that we shouldn't do. But this certainly suggests that there's very likely to be a benefit. There's a lot of other data that then corroborates this. And this is from Lavina Muncionetti Fan. This is a systematic review and meta-analysis of 5 studies of ECMO, including those 2 randomized trials and 3 observational studies. And they based the primary outcome of 60-day mortality just on the 2 randomized trials, which I'll show you here, this is a forest plot showing the diamond to the left of one, again, favoring ECMO. So the 60-day mortality was 34% with ECMO and 47% with controls. This is now an individual patient data meta-analysis putting together the Eolia and Caesar trials by Alan Combs and Giles Peak. This is published in Intensive Care Medicine, again, showing that the ECMO group had a much better mortality. This is one of 2 network meta-analyses of randomized trials of ARDS. This is by Sachin Sood, looking at 34 trials of 9,000 patients using very sophisticated methodology. They were able to show that prone positioning plus standard low tidal volume ventilation was the best strategy. But that VV ECMO was also rated among the best strategies, just with low certainty because it was restricted to these very few patients with very severe ARDS. Putting all of that together, this is now going back to the JAMA trial. This was the editorial written for the post hoc Bayesian analysis, again by the editors from JAMA. So sort of putting the imprimatur of JAMA on the conclusions that they had, which is clinicians and researchers should no longer ask, does ECMO work? Again, this is their opinion, because that question appears to be answered. Instead, the key question should now be asked is, by how much does ECMO work, in whom, and at what cost? So that if you believe that viewpoint, and now with all of that data in totality, and we come to accept that ECMO probably does have mortality benefit in the setting of very severe ARDS, as long as you're using criteria similar to Eolia or the Caesar trial, then when should we be using ECMO for ARDS? Well, it should be part of a standard management algorithm. This we published in the Lancet Respiratory Medicine. The most important thing is always to treat the underlying cause. If they have pneumonia and develop ARDS and you don't treat the pneumonia, it doesn't matter if you put them on ECMO. Standard lung protective ventilation, depending on their hemodynamic status, diuresis or resuscitation. And then if their PDEF ratio remains below 150, prone positioning, unless it's contraindicated, is really what's strongly recommended. And then these other interventions might be considered as well. However, if they then meet criteria per EOLIA with no contraindications, even after having put them in the prone position and done whatever other maneuvers you think are appropriate in that patient, then that's when we would put them on ECMO. So that's really the general management, or at least the general approach to ECMO based on the data. And how should we manage COVID-19 related ARDS in comparison to ARDS in general? This is a paper we put out early in the pandemic with Eddie Fan in the lead from Lancet Respiratory, really as a call for adherence to the current evidence-based algorithm until there's evidence to the contrary. Remember, there was a lot of controversy at the beginning about how ARDS in COVID is very different from non-COVID ARDS. There are definitely some distinctions, although overall, it does seem to be under the umbrella of the syndrome of ARDS. However, there's nothing to suggest so far that we should do things differently than we normally do. There may be at some point, but currently not yet. And so we should follow this very same algorithm for our ARDS patients, including for the provision of ECMO. So what is the role of ECMO in COVID-19 related ARDS? Let's talk about some of the evidence that's come out. There's actually a few recent papers as well. This is one of the first really nice papers from Mathieu Schmidt and Alain Combe from Paris, published in Lancet Respiratory Medicine. This is from 5 ICUs in Paris with 60-day follow-up, and it's 83 patients. Just of note that 79 of those patients came from La Pitié-Salpêtrière Hospital, which is the hospital that Mathieu and Alain practice in. This is what's called a stacked bar plot, just looking with patients still in the hospital, excuse me, at those alive and out of ICU, those who had died here. Here are those in the ICU and weaned off of ECMO, still in the ICU. And these are the ones who are remain on ECMO, so very few by the time they're reporting the data. The estimated probability of mortality at 60 days was 31% and 36% at 90 days. So very similar to EOLIA. So then this is a very recent publication from a couple of weeks ago. This is updated data from Paris, led by Guillaume Le Breton and Pascal Leprince, also from Le Pitié-Salpêtrière Hospital. This is now looking at 17 ICUs throughout what they call the Greater Paris ECMO network, which was put together during the pandemic. Very impressive effort. So this is patients with COVID-19 ARDS from March through June, or through the beginning of June. And they had central regulation of their ECMO indications. They pooled their resources, and they had 6 mobile ECMO teams, only one of which existed prior to the pandemic. So 5 of them were created in the setting of the pandemic. All told, they had 302 ECMO patients, median age of 52, mostly men, which we're seeing in all the studies. 55% were transferred by mobile ECMO, and the 90-day mortality was 54.3%, which is higher than we saw in the others because now you're combining 17 different ICUs, including some with less experience. And this is case volume, so center experience. The outcomes were much better if you did at least 30 cases a year as compared with less than 30. Mobile, whether you were transferred or not with mobile ECMO didn't make a difference. Age, as we've seen throughout the pandemic, made a significant difference. This is less than or equal to 48, 49 to 56, or greater than 57. And here you can see the days between intubation and ECMO. If they were less than 3, you did better as compared with 3 to 6 or greater than 6. The experience from Chile, you may have seen, was just published by Rodrigo Diaz and colleagues in the American Journal of Respiratory and Critical Care Medicine. They also had they looked at their nationwide Chilean cohort of ECMO for COVID-19 from March through August. And they looked at a linked national agency's database and found 94 ECMO patients. And they were able to dive deeply into 85 of those cases. And their 90-day mortality was 38.8%. Again, this is from the first wave. We're seeing a very consistent mortality for the most part. What about in the US? There is this paper from the Stop COVID investigators published in Intensive Care Medicine. Here it's 190 patients from 35 hospitals. And they looked at the data, and then they did what's called an emulated target trial, which you may have seen a few of these recently. I think you're going to be seeing more of them over time. And it's basically a way of taking observational data and statistically trying to turn it into what would be a randomized trial. It's very tricky statistical techniques to try to understand what the data could potentially show us that emulates a randomized trial. They looked at ECMO within 7 days with a p-def less than 100, so a fairly generous p-to-f. But you can see that the mortality with ECMO was 34.6%, and without ECMO, 47.4. Again, very consistent data. And here you see the unadjusted survival curves, again, favoring ECMO. And now the international experience, and this is from our ELSO publication. This was in The Lancet last fall, and I want to point out my colleagues Ryan Barbaro, Graham McLaren, and Phil Boonstra did tremendous work on this. This was based on a COVID-19 registry addendum that we created for the pandemic. This is the first 1,035 COVID-19 patients entered from 213 centers across 36 countries. And we wanted to look at the epidemiology, hospital course, and outcomes of these patients using a multivariable Cox model, and that was to look at patient and hospital factors that were associated with in-hospital mortality, looking at 90 days of follow-up from ECMO initiation. And we don't know what happens to the patients after they're discharged from the primary hospital. It's just data that's not available in the registry. This is the estimated cumulative incidence of in-hospital mortality 90 days after starting ECMO, and it's 37.4%. Here, just to give a sense of the stacked bar plot, these are the patients who were discharged to home or rehabilitation. Here are the patients who had died. Very few patients still hospitalized, some where the status in the registry wasn't updated, so it's censored. And these are patients who are discharged to another hospital or discharged to a long-term acute care facility or unspecified. And this is still a fairly large number. So these are estimated mortalities, the 37.4%, because you still have patients who may or may not have survived, and we don't have final outcomes on them. What factors were associated with in-hospital mortality? Age, very strongly associated with mortality according to decade of life, 40s, 50s, 60s, and at least 70. Immunocompromised status, chronic respiratory disease. If you had an arrest prior to ECMO, your mortality was higher. And if you were started on either veno-arterial or veno-venous arterial compared to veno-venous, you had a higher mortality. This is from the European version of ELSO, Euro-ELSO. This was a survey of COVID-19 patients in Europe and Israel, led by Roberto Lorusso and Jan Bolovic from the middle of March through the middle of September. They had a total of 1,531 patients, so it's the largest population reported so far, but it's a survey, so not as in-depth data. This is from 177 centers throughout Europe. Mean age, again, 52, 79%, and very similar data. 91% were veno-venous. Mean ECMO support of 18 days and ICU length of stay of 33 days, and their overall mortality was similar to the other studies at 45%. What about one study with a little bit of a different approach? You may have seen this. This is Asif Mustafa and colleagues published this letter in JAMA Surgery. They're from Chicago in the United States, and this was the first 40 COVID-19 patients that they treated, all of whom met EOLIA criteria. And they have very good outcomes that I'll show you. And so the question is, why do they have good outcomes? And they decided on a package of interventions early on in the pandemic that they did for all these patients. And there's a lot of focus on the fact that they use the Protect Duo cannula, which is a right atrium to pulmonary artery, very much like, very similar to a pulmonary artery catheter, but it's a dual lumen cannula for ECMO. And because it bypasses the right ventricle, is a right ventricular assist device and often is used as that. But when you add an oxygenator, is really VV ECMO with RV support. But they also use direct thrombin inhibitors instead of heparin, very high doses of glucocorticoids even before the recovery trial came out, inhaled nitric oxide, and their goal was to extubate patients during ECMO and do physical therapy. And so somewhere in that package of interventions, but some of that may not be necessary at all, but we're not sure which of those resulted in these good outcomes. And so here you see the number of patients initiated on ECMO up to the 40th, patients who were extubated, and that was at a median of between 11 and 13 days, decannulated, discharged from the ICU, and then discharged from hospital, which was not total follow-up. So 15% mortality when they locked the database, but 11 patients were still in hospital. So what happened to those patients? This is a follow-up letter to JAMA Surgery where all 40 patients had complete reporting, and still the mortality was very low at 17.5%. So just very interesting to keep in mind that they had a different approach and still do, and now they've done well over 100 patients with that same approach. Their mortality has crept up, as I'll show you. That's true of really all centers in the second wave. So here's the mortality that reported in the Lancet paper, 37.4%. But I just wanted to point out that this is more recent data from the ELSO website, which you can follow anytime. It's available online. With over 6,000 COVID-19 ECMO patients now, including that first 1,000, the total mortality is 50%. And if you take out this first 1,000, it's higher. It's probably about 54% or so. And so it's just to let everybody know that I get calls all the time from centers saying, hey, our survival rate is not as good since the first wave. Are you seeing the same thing? And this is data that shows that actually is true. In the first wave, the international data showed 37% mortality and is now, since that first wave, in the mid-50s. And so the survival is definitely not as good. So just to conclude, the use of ECMO during COVID-19 should remain part of the standard ARDS algorithm, but clearly we need more evidence to really understand what we should be doing and who is most appropriate for ECMO in COVID-19. Thanks very much, and I'm happy.